This is Finn Voices on the Healthcare Now Radio, where we highlight and amplify the voices at the forefront of health innovation that improves people's lives. One is for an inside look at the change makers driving conversation and answering the most important questions in healthcare today. Thanks for joining us.
Welcome to Finn Voices. I'm Joe Foster, your host, and today we have a special guest, Dr. Leon Igel, one of the premier experts in obesity treatment in the U.S. Dr. Igel was a clinical assistant professor at Weill Cornell Medicine and an attending endocrinologist at New York Presbyterian Hospital and Weill Cornell Medical Center. Dr. Igel has expertise in various endocrine conditions, including obesity, diabetes, polycystic ovarian syndrome, and bone and thyroid disorders. Dr. Igel is board certified in internal medicine, obesity medicine, and endocrinology. He is also a fellow of the American College of Physicians and the Obesity Society. Today, we will focus on Dr. Igel's role as Chief Medical Officer for Intellihealth, a leading health tech software and clinical services company that delivers a comprehensive and clinically proven medical model for treating obesity. At Finn Voices, we specialize in offering a peek behind the curtain of innovation with the health sector's leading change makers and focusing on better health outcomes for all. Let us welcome Dr. Leon Igel to the show. It is a pleasure to have you here.
Pleasure to be here. Thank you for having me.
You bet. So Dr. Igel, I know there's some really exciting things happening at Telehealth right now, but before we get into that, I'd love to talk a little bit more about you. I know I gave an overview, but let's get a better sense of your background. Can you tell us about your expertise and your experience in the field of obesity treatment?
Happy to. And so actually, my exposure in the field goes back to taking my father to his first appointment with Dr. Lou Aroney in the early 2000s. And that was really my first exposure to a field of obesity medicine that barely existed at the time. And he was actually able to get my father on a much healthier path and totally revamped his medical regimen. And when I saw Lou in action, really changed my career trajectory at that time. I was, in medical school and really trying to figure out which way I wanted to go. And Lou was so gracious, and he allowed me to join him on a variety of obesity-related projects and research endeavors, one of which was called Cardiometabolic Support Network, which was sort of the precursor to the precursor of Intellihealth software platform. And then during my years in medical school, where I was at Albert Einstein for medical school, I was working with Lou on a variety of different projects, and then subsequently attended Weill Cornell for both my internal medicine residency as well as my endocrine fellowship. My endocrine fellowship was at Weill Cornell, Memorial Sloan Kettering, and Hospitals for Special Surgery. And I continued to work closely with Lou and publishing articles and learning kind of the tricks of the trade. And during my residency, I was able to establish a weight management practice for the residents and created a weight management elective during the residency to help others gain exposure in the area. And then I eventually joined the Weill Cornell faculty and took over as program director for Cornell's Obesity Medicine Fellowship and also the Obesity Medicine Bariatric Endoscopy Fellowship, and later became director of Weill Cornell's Comprehensive Weight Control Center on the west side of Manhattan. And kind of the natural next step was to broaden to the Intellihealth sphere, where we have been able to expand the sort of scope of obesity medicine to treating across the continental and United States. So the natural next step was to expand to Intellihealth and enable the treatment of obesity across the United States. We've been so kind of centric and focused on care in New York City. And the intention now is really to take all of those learnings and really expand that nationally. So as of last year, I had the good fortune to expand my role to Chief Medical Officer at Intellihealth. And in the past year, we've grown our clinical services division called Flight to have providers treating everywhere in the United States. So it's really quite an endeavor, and it's been a real experience, but also something that I think has been really near and dear to my heart as a sort of a mission statement, and something that has been a wonderful experience so far.
Yeah, to make that available to the broader group of people, that's so essential. That's so great. It's great the work you're doing there with the telehealth, and we're going to talk more about that in a minute. I'd love to break it down and like go back and I know this year was the anniversary for the AMA declaring obesity officially a disease. So I'd love to talk a little bit more about obesity and sort of the root causes and contributing factors of obesity that you've observed in your work over the years.
Absolutely, yeah, and that's such a critical piece of this. I think first and foremost, I look at genetics, and while our genes are certainly not destiny per se, I think there's a really close link between sort of nuclear family familial obesity and someone developing obesity at some point during their lifetime. And we often like to start our conversations within, the Intellihealth light experience, kind of letting folks know that obesity isn't their fault and that it shouldn't be viewed differently than any other medical condition. When someone says they have hypertension, for example, no one blames them for having that condition. But when it comes to obesity, there tends to be this sort of inherent underlying bias that assumes that the reason obesity has occurred is because someone is either eating poorly or not doing enough exercise. And we kind of try to dispel that. And that's where we know kind of genetics really factors into so much of this. There's one person who eats a perfect diet, but has the genetics of weight gain, kind of not in their favor. And it just makes it so much harder to maintain weight and not gain throughout the lifetime. And that's a huge piece of this. And then other things that we see that are actually quite common are what I refer to as obesogenic medications, meaning medications that kind of contribute to weight gain. So we know that at least 20 to 30% of individuals in the United States are on one or more obesogenic medications. And many of them fall into categories of really common medical conditions like type 2 diabetes or hypertension or depression and anxiety. And there's antipsychotics that cause that or anticonvulsants, but so many can contribute to weight gain and account for a large percent of individuals who struggle to lose weight or just find their weight climbing over time. And, again, just speaking on the, flight and telehealth side, we really evaluate all of those components when someone comes into our, treatment center to look for either weight neutral or weight loss promoting replacements for existing medications that may be making that whole process of weight loss a lot harder. So it's a big component of what we end up seeing kind of as a major contributing factor.
That's interesting. It's just, that question, and having the first thing that you say is genetics versus, eating right and doing more exercise. My doctor, I've struggled with weight for many, many years, and my doctor has never once talked to me about anything other than I need to do more on those two fronts,
Absolutely. And I think the general guidance that folks receive is you need to, eat better and exercise more. And of course, there's some people who maybe do need to do that, but there's so many other contributors. I would target and say that stress and poor sleep really dysregulate other hormones in our system, cortisol and other metabolic abnormalities, conditions like obstructive sleep apnea when is very underdiagnosed and contribute to ongoing difficulty with weight loss when and until they're treated. And then we do have some folks who, again, the environment is really set up to make weight hard to lose, right? Like when you look at what food is really fast and readily available, fast foods that we call ultra processed foods that are really, really palatable and actually very addictive. Those kinds of foods they're manufactured to become addictive in that regard. They account for the majority of the calories that are consumed in the United States when I'm referring to ultra processed foods. And the food industry has really done its best to make folks want to eat more and more of those types of foods. Even certain slogans, are honest about that, right? Like Pringles of once you pop, you can't stop. Like those kinds of slogans, they're honest about the fact that, they know their foods are addictive and they've created food to be as addictive as it can possibly be. It's on par with illicit drugs in many ways. Like the classical research studies that actually look at this, they take rats and they offer them cocaine or they offer them sugar water. And the rats actually have a really strong preference for sugar water, regardless of the kind of the strength or dose of the cocaine water that's made available. So when you think about something being addictive, and you can say sugar is actually more desirable than cocaine at a sort of organic level, that's something to really, comment on. And it's set up to cause people to have trouble with their weight.
Wow. So that really hits, you're driving home the cause piece of it, and a lot of those factors. That's great. What are some of the health risks that we're talking about that obesity brings to the table?
Yeah, obesity is closely associated with over 200 conditions, and some of the most pervasive medical problems that we see, kind of in all comers. So type 2 diabetes, prediabetes, high blood pressure, high cholesterol, heart disease, stroke, and many psychological issues, poor self-esteem and depression, sleep apnea, fatty liver, joint disease and osteoarthritis, even a variety of cancers, breast cancer, uterine, colorectal, just to name a few. It's a really long list, and I'm just kind of spitballing off the top of my head. But that list is long, and we recognize that when we treat the etiology, the root cause, when we treat the obesity, so many of these underlying conditions either improve or resolve, depending on which ones we're talking about. And that's really at the heart of treating weight, is not just having someone go to a lower weight, but it's resolving the associated health risks at the same time.
Right. Yeah. I can't help it whenever I go to a news site or anywhere, especially recently, seeing the news about the new GLP-1s that are being approved to combat obesity and diabetes. Can you talk a little bit about these GLP-1s and the impact that they're having and why they're important?
Yeah, no problem. The GLP-1 family of medications are a class of medications that are very effective. And, I can kind of go through maybe I should take a step back and talk a little bit about sort of our treatment approach, and kind of start there, and then maybe broaden as I get to it to talk about the GLP-1s, because there's a lot I could say on the GLP-1s, but, maybe taking a step back, I'd like to first say that, we sort of pride ourselves in personalizing and individualizing care for individuals with weight issues. And, in all of my years, I haven't seen two identical cases, and everyone has different underlying challenges and health conditions that are unique to them. So the treatment strategy really needs to be unique as well. And so we ask our patients to complete a very, kind of comprehensive metabolic lab assessment before their first visit, along with a series of questionnaires to better understand their unique perspectives and challenges. And then we look at some of the items that I previously mentioned. For example, if someone's taking one or more obesogenic medications and whether there are reasonable alternatives that could be employed. And then we think about the areas that each person may find challenging. So is someone struggling with portion control or intense cravings? Are they eating emotionally or eating late at night or in the middle of the night? Or perhaps they don't experience any of the issues I just mentioned, but they just entered menopause and they're finding their metabolism is now slower and their weight is climbing. We have treatments that can readily target kind of any of those areas. And the sort of special sauce is in matching, the right treatment to the right person and avoiding, the one size fits all kind of solution that many companies seem to think is the right way to approach that. That would be the same thing as saying you use the same chemotherapy for every cancer. You just don't use the same medication to treat every individual case of, obesity. So that said, there's definitely no silver bullet for all comers, but some of the most effective medications on the market today are the GLP-1 family of medications. And those names have become more and more familiar due to kind of social media and, medications like Wegovy and medications like Ozempic and even Mounjaro are now kind of more mainstream names that people have heard. Wegovy is FDA approved for obesity. Ozempic and Mounjaro are currently FDA approved for type 2 diabetes, but they also happen to be very effective for weight loss. And just to clarify, Ozempic and Wegovy are actually the exact same medication. They're both semaglutide, but they just received different names for the different conditions that they're approved to treat. And then Mounjaro, or the ingredient in Mounjaro, tirzepatide, is currently being reviewed by the FDA for approval for obesity management. So, those are some of the ones that these days have been used very frequently for weight loss because they achieve such a significant weight loss, anywhere from average of 16% body weight loss for something like Wegovy, and something in the 20 to 22% body weight loss for something like Mounjaro. So you're really looking at, nearly bariatric surgery weight losses from just a single medication when you start talking about Mounjaro. If you think of like a sleeve gastrectomy as having an average of a 25% body weight loss, for many folks on Mounjaro, you're getting that kind of weight loss just from its use alone. And interestingly, there are medications in the pipeline that are even more effective and kind of let us get a sense of where the field is going, in the future.
If you're just tuning in, I'm Joe Foster, and you're listening to Fin Voices on Healthcare Now Radio. I'm talking to Dr. Leon Igel from Intellihealth about the issue of obesity, new game-changing treatments, and the road ahead. Welcome back to the show, Dr. Igel.
Thank you again for having me.
Before we took our break, we were talking about some of these GLP-1s. And you know what? Could you tell the audience what that is exactly, a GLP-1?
Yeah, happy to. So GLP-1 is a hormone that's released from the intestine naturally. So everyone, regardless of who they are, makes GLP-1 naturally in the intestine. And what we know now is that the medications that we're referring to, the Ozempics, the Wegovys, the Mounjaros, they are receptor agonists, meaning they kind of stimulate more of that hormone in the body, that hormone that you're already making. And those hormones are responsible for satiety, meaning like sense of fullness, and they impact the speed of the stomach's emptying. So you feel full longer and full faster. And you also have improvements in glucose if your glucose starts out elevated. So it can help in a number of different ways for both appetite. Most people will find that the size of the portion they need to feel full is significantly reduced, and the frequency that they need to eat is also lengthened quite significantly because the food is staying in the stomach longer and making you feel full for much longer. So folks who tended to snack in between meals find that they don't need snacks, and folks that started with needing a full plate of food now are pushing a portion of that meal to the side. So it can make a real difference when typical dietary strategies just cause someone to eat. They know they need to eat less to lose the weight, so they try to do that, but they're ravenously hungry while trying to do it. This actually offers that sense of fullness with far less. So you're not feeling that same deprivation that tends to have people deviating on their diet and eventually giving up and going back to what they were eating before.
I know we got a few minutes left, so let's jump and talk a little bit more about Intellihealth and the treatment that Intellihealth offers. Can you break that down for us?
Yeah, so Intellihealth actually offers a number of different treatments from within it. But what I would say the crux of Intellihealth is that right now, very few providers feel comfortable treating obesity. And the ones that do may not be in close proximity to where someone lives. So access to qualified obesity medicine specialists is really quite limited. In the United States today, there are roughly 100 fellowship-trained obesity medicine specialists and only about 6,000 physicians who are credentialed by the American Board of Obesity Medicine. So if you take those numbers and compare them to the 70+% of the US population with either overweight or obesity, there's kind of a distinct mismatch. And most individuals would have to drive very long distances or many hours to gain access to a center of excellence for weight management. And then the wait times to see those folks can be really lengthy. So that's really why we created Flight. Flight is the clinical services division of Intellihealth. And that's really to offer telemedicine care to every state, essentially from the comfort of your own home, with care that exceeds what typical in-person weight management care would look like. And we focused on expanding access to that type of care, which is really not taught in medical school or residency training, at this point in time.
Got it. You mentioned flight again, and are these services, the treatments that you're offering, are they for individuals, or are you providing them to employers or providers?
So the answer to that question is yes, but typically the most common way that we partnering with an employer or a hospital system in kind of a business to business relationship, and we'll treat a whole company's employee subdivision or what have you, and that's the most common way that we would create those relationships for treating individuals. Although I have to say that organically, we also have a number of folks who just come to us because their sister, their brother, their mother, their father did so well. And, that person shares where they were treated. And so there's this organic growth that occurs from individual sort of success, separate from the business to business model that we've created as sort of the backbone of the company structure.
Yeah, that's good. Let's talk about those successes a little bit more. Are there any success stories or case studies you can share that involve Intellihealth solutions having improved patient outcomes?
Yeah, so just being mindful of sort of patient privacy, I can certainly share my father's weight journey because, he's someone who's given me permission to share it. So that may be one of the easier ones if that's interesting to hear about.
That would be great.
So as I mentioned, I guess earlier here, that my father first met Lou Aroney, that is, who's Intellihealth's, co-founder and chief scientific officer in the early 2000s. And at that time, he weighed 320-ish, I don't remember, 318 or 320, right around there on a 5'10" frame. And he was on 4 medications for blood pressure, another 4 for diabetes. And many of them were actually contributing to weight gain, frequent hypoglycemia, meaning, episodes of low glucose, and other issues like shortness of breath. He was actually to the point where it was hard for him to walk to and from the bedroom to the kitchen without having to take a break to sit down and rest. And he would need a cab. We're in New York City, so he would need a cab even just to go a few blocks. He wasn't able to walk that under his own steam. And, Dr. Aroney started to adjust his medications, and the frequency of his hypoglycemia and the shortness of breath resolved, and his appetite started to lessen. And we started to see kind of the weight just melt off of him. And he worked with Dr. Aroney for a number of years, with me eventually kind of adding in my 2 cents, continually refine his treatment. And he continues to be treated through Flight and Intellihealth currently for his ongoing care. And just in the past year, he's taken off another 30 pounds. It's been a long time that we've been, of course, managing him. And he now weighs 160 pounds with a normal hemoglobin A1C. So, diabetes entirely in remission. And he's only on 1 medication for his blood pressure control. So he has literally cut his weight in half compared to where he started without requiring any surgical intervention. And his diabetes is in remission. And he's had similar improvement to all of his other health conditions. So it's really been, he's a prime example of someone who needs to work with a medical team that understands not just how to manage weight, but knows how to manage all the weight-related medical conditions and can offer that comprehensive and individualized care that our team can offer.
Wow, that's amazing. That's just such a dramatic shift. And it sounded like the treatment it continued for quite some time though, right?
So it did. I mean, I think what's so different about the early and mid 2000s is that the options that we had available for treatment were much more limited. In 2005, we had the first GLP-1 medication made available in the United States. And that medication is called Byetta. So it wasn't as mainstream because it was injected twice a day, and people don't love doing multiple injections per day. But my father was actually one of the first people to start Byetta and had a really good response to it amongst other medications. So, GLP-1s, as you mentioned, are getting a lot of, press and hype right now, but they've been around since 2005. So again, we're thinking about it in 2022 and 2023 so much more because they're now weekly and they're, much more effective. But we have really a long track record of those types of medications being available, and they've just improved. Each newer version coming to market has achieved, kind of easier. They've gone from twice a day to daily to weekly they further
pill form. I've
exactly,
seen that.
yeah, even more to the point, right? Like now you can actually take them as pills as well, and you can improve A1C and weight so much more with them now. So his entire medical regimen has advanced sort of as the field has advanced over these past, 20 or so years. But I can tell you, kind of looking at it longitudinally, that he's in, a great place because of when he started getting treated and how that treatment occurred.
Right. So talking about all these medications and different things changing so quickly, what do you envision the future? What do you see in the future for treatment? Any trends or approaches that you think are going to be different than where we are now?
Yeah, I mean, I think as the medications available and our armamentarium continue to improve, I think medical weight management will become even more essential to treating all of the other weight-associated medical conditions. And one of my greatest joys is when we can help someone lose enough weight that they come off multiple antihypertensives, or they no longer need a CPAP for treating their, sleep apnea, or their diabetes is in remission, and they tell me their quality of life has improved and their energy and their mobility have improved. We often treat folks who have trouble walking down a flight of stairs or are contemplating joint replacement surgery because they can't take the stairs to the subway or stairs in their house, without significant pain. And the newer medications, which I can talk about, are ones that I think in the next few years are going to really change the landscape of what we have available. And I actually hope that long term, we'll also have better pharmacogenomic testing where you can kind of match very specifically the treatment to the person in that sort of precision medicine way. So I think, that's going to be a really significant step into the future as those tests also improve.
Yeah, it really does feel like it is the golden age of obesity treatment, and more importantly, the golden age of like helping people that have needed help for quite some time that haven't had access to it. Thank you so much, Dr. Igel, for joining us on Fin Voices and Healthcare Now Radio. For our listeners, you can learn more about Intellihealth and their Evolve and Flight Medical Services and Dr. Igel by visiting intellihealth.co, or you can visit flight.com, and that's flight, FLYTE.com, or you can go to the company's Twitter page at Intellihealth1, or the number 1, sorry. I'm Joe Foster with Fin Partners, and you can follow me on Twitter at FosterFriend. And please continue the conversation using the hashtag FinVoices. And I'm sure our listeners today found the conversation illuminating. Please, learning more about you and Intellihealth's impact, providing better health solutions for people across the U.S. Thank you, Dr. Igel. We appreciate your time.
Thank you again for having me. It's been a pleasure.
Fin Voices is brought to you by Fin Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact in the world around us. Learn more at finpartners.com and follow us on Twitter